Everybody to the Dean's Distinguished Lectureship. I'm super excited to kick off this academic year with Bhramar Mukherjee. So let me tell you a little bit about Bhramar. I think she's somebody that does not require a lot in the way of introductions, but I will share with you my view on Bhramar. So there's the official stuff, like she's the Kalbfleisch Collegiate Professor at the University of Michigan. She chairs one of the largest and most prominent biostatistics departments in the country. Just finished her 5th year as dean.
As chair.
I mean, sorry, as chair.
Thankfully not dean.
Chair. Same. As chair, and we're going to do a little quiz around that in a second. But I got to know Bhramar from her work on COVID in India. She and her team built these COVID models that became the gold standard for really understanding and tracking what was happening in India. And 2 years ago, when India had the horrible Delta wave, Bhramar was the first person that I know of who basically called it weeks, if not months, before the Indian government came to recognize what was happening. And I want to say it was like late February, March, that you were the first person to say, we have a problem. And of course, everybody ignored it for a while until it was hard to ignore. And what she exemplifies is phenomenal data science and research, but put into action. And her work, I think, has had more impact on thinking about COVID in India than anybody else. That is very much the kind of intellectual leadership that then gets translated into practice that has come to very much exemplify Bhramar. The other part I want to talk about just very briefly is her work, and I think she'll cover some of this stuff today, is, as you all know, there has been this just explosion of data, and in healthcare, particularly around electronic health records. And one of my kind of favorite set of work that she has done has been looking at electronic health record data, thinking about what are the biases, what are the misclassifications. And we've learned in the last few years that if you don't think about those things very thoughtfully, and if you don't take a very systematic approach, you can get the answers pretty wrong. And I think there was a paper of yours from 2022, a year and a half ago, that talked about kind of empirical approaches to fixing a lot of those selection biases. This is the kind of work we need if we're going to use this explosion of data to make sense of things. So I'm super excited about her lecture today. As you might imagine, as somebody who's a collegiate professor in Michigan, chair of the largest biostatistics department, she's won all sorts of awards. She's a member of the National Academy of Medicine as of a year ago, which is very exciting. And I could not think of anybody I'd rather have kicking off this year for the Dean's Special Lecture. So, Bhramar Mukherjee.
Thank you. Thank you so much, Ashish, for the exceptionally generous introduction. I'm not sure I deserve it, but I'll take it. So I have been speaking endlessly about COVID-19 in India and also criticizing the data paucity and data obesity of the Indian government. And so I felt like for a change, I'm going to criticize the US government. And also not having an integrated national digital health system. And that has led to many of the challenges that I'm going to talk about today. And I'm exceptionally grateful to be the inaugural Dean's Visiting Lecturer at Brown, and I'm so happy to be back at Brown. So I met Ashish in a TV show, in the green room of a TV show. And Indian TV shows are like a screaming contest. I don't know about many channels, probably in the US. And suddenly there was this sophisticated voice of sanity. And I said, who is this person? And then I looked him up, of course, the legacy and the incredible work Ashish has done. But I just looked up, it was exactly 3 years ago that we were on this television show, and we all have come a long way. And both me and Ashish probably worked round the clock because we took a nap in the evening and then went back onto the Indian TV channels in the late nights. And also all my meetings with the Indian government and policymakers were quite late at night. So that was the time that I definitely do not want to go back, but I want to congratulate everybody, including many in this room, who did incredible science, incredible global science from their bases. So kudos to our community for rising up to that challenge. So then, actually, my first trip after the pandemic, or I don't think it's quite after, was in September of 2021 when Ashish invited me to participate in a COVID-19 pandemic symposium focusing on the global south. And that's what that was at the Watson Institute. And I had the pleasure of going to dinner with Ashish, where he was an absolute celebrity. Everybody wanted to take photos. I was like, wow, epidemiologists and biostatisticians do not get this honor. And everybody was telling me how lucky I was to be at a dinner table with Dean Chow. So I saw the aura, and I was like, well, this is good. Our profession is getting some traction. But then Ashish went on to do great public service for the nation. But I'm so glad that you're back in a university and absolutely admire the work that you've done. Thank you. So I wanted to tell you a little bit about myself. So I was always a math nerd, and I'm still a math nerd. And I used to read math book inside novels and fictions because my entire family is full of liberal arts people. My father is a very famous actor in India that will come back to my talk. And then I have been a statistics major, I just counted, which is impossibly depressing, for 32 years. So I love statistics, and I did all kinds of degrees in statistics from all over the world. And I have been in Michigan Biostatistics as an assistant professor from 2006, and I have had a fantastic career at University of Michigan. It's an institution that I very much love. One honor, it was mentioned, has been to be the first non-male chair of Michigan Biostatistics in 2018. It took us more than 70 years to get there. We had incredible chairs in the past. It's very hard to envision yourself as a leader after they have created this whole big mess. But I think that I'm very, very honored, and this is probably the most incredible thing that I have done in my entire career. I totally believe that women are not presented with leadership opportunities as frequently as men, and when the time came, even if I was not ready, I jumped into it and I tried to do my best. This is a quote from one of my favorite statisticians, Dr. Janet Norwood, an incredible statistician and policy statistician. So I am very, very happy that in the 2023, I have in 2018, we were Michigan Biostatistics was at number 5. Of course, we do not like the ranking when they do not go in our favor, but we talk about them when they do go in our favor. So in the latest ranking in 2023, Michigan Biostatistics was the number 1 public biostatistics department above UNC and UW, our arch rivals. So I was quite happy. And Hopkins and Harvard were very close to them. And so I felt like I was on top of the world, and so I did go to the expedition to Mount Everest. And so you can see me on the world's highest helipad at 17,500 feet altitude on May 29, just like about 2 months ago. And that was the Everest day when Edmund Hillary and Tenzing Norgay first set their foot on Mount Everest. So this is just like, this has been an incredible year, finishing 5 years, and so I'm very, very delighted to present this lecture this summer, which has been a very special summer. So my first quiz, as a statistician, statistics is actually a relatively new field. If you compare it with mathematics or physics, it's a relatively new field. There's this incredible paper by my colleague Alan Agresti, how statistical textbooks have actually influenced our field. And this book tells us, and it made me reflect on, when was the first statistics textbook written? Approximate time interval. Anybody would like to guess? Pure, not a math book, just with statistics in the title. 60 years ago? 60 years ago. I'll tell you that it is in the 20th century. That's a big guess.
20s. 1920s.
1920s, Andy's guess. Close. Alright, so I'm going to give this candy bar to Andy because thank you, Andy, I deserve it. And this is a Michigan swag, so we deserve to totally. And so it's actually 1901. It's actually 1901 where an economist, Arthur Bowley, at the London School of Economics, actually wrote the book called Elements of Statistics. This is historically the first purely statistics book. This also iterates that economists always teach statistical ideas. But I'm not going to talk about that. That's a very controversial topic. I'm not going to get into that. Before I begin my talk, I just want to say that building on this history of models and statistical models, probably we have come at a point where we are all grappling with two elements in statistical science. One is causal inference, and also I don't think just statistical science, all across humanity. Causal inference and machine learning, large language models, and all of this stuff that is coming at us in a very, very rapid way. So if I could design a course in terms of my aspirational research philosophy, I'll really change how we teach statistics. I'm not going to start with linear model and generalized linear model and say y equal to x beta plus epsilon. I'm not going to go there. I'll actually go back to theory of causal inference. I will, in terms of thinking about a scientific problem where a treatment or an intervention or a policy works or not, think about that problem, think about the assumptions that will make, like think about the estimate that you're after, what do you want to estimate, and when can you estimate them based on observed data? So do the math when they're identifiable, and then think about all of the tools. I want my students not to pledge allegiance to one kind of doctrine of statistics, but no Bayesian frequentist machine learning, many different theories, some may be deeper than others, but many different tools to get at your estimate. So I feel like, I run an undergraduate summer program on big data, and we teach actually counterfactual and potential outcome to math undergraduates first, and then talk about ways to get to the estimate. So I feel like with that, different cultures coming together, different kinds of thoughts together, we are needing new kinds of statistics and thinking for the era of large N, where millions and millions of observations from large databases are being amassed. And for these large heterogeneous data structures, like the real-world healthcare data or electronic health records, it's actually even more of a statistical sin to start with the linear model that it holds for the entire data set. We also now have tools to go for more assumption-lean methods, which does not have so much of a structure. But still, core statistical ideas and models have their value, as I'm going to try to explain to you. But I think assumption-lean methods, causal thinking, is governing some of these large N problems that we are looking at these days. So as I said, that my father is an actor and director in India. During COVID, when I was doing a lot of this work and giving a lot of lecture on Zoom and on YouTube, I made him sit down and listen to one of my lectures. And he was silent. And I asked him, what was wrong? I'm a pretty good speaker, I'd like to say. And he said, have you ever heard about the word pause? We do not use pause. We have so much to share with you, my audience. There is so much knowledge to impart in 40 minutes that you have given me. How can I pause? But then since then, I have started to divide my talk into acts, following sort of his advice, being a good daughter, and divide it into 3 acts. And after each act, you're going to have a little musical interlude. In an actual theater, if you don't like the play, you are going to leave. But here, that would probably be impolite, but you're welcome to. So I am going to structure the talk that way and see how that goes. I have to thank my team, my collaborators, and they come from genetics, epidemiology, computer science, and causal inference. And all of us work together on this problem, trying to understand and analyze electronic health record data better. So the first act is really about how to be part of big data science or data making initiatives. You hear this word all the time that statisticians play in everybody's backyard and take other people's data and do lots of fancy models and enable others' research. So I don't see a reason why instead of playing in other people's backyard, we could not have our own garden or our own forest or lead studies or be part of data making. So I started my first foray into this as a part of a university-wide initiative called the Precision Health Initiative. It started in 2012, and the goal was to create a linked data repository or data ecosystem which many people can use and which serves as it's a sort of disease-agnostic biobank where it can act as an accelerator and incubator for ideas, either validating existing hypotheses or for agnostic queries. And I was not in charge of data analysis. I was actually in charge of cohort building. On whom do you collect data and what kind of data do you link this data set to? And so the first cornerstone of this precision health is this Michigan Genomics initiative. We have recruited 100,000 participants with genetic biosamples linked with electronic health records through a very simple consent form. And the consent form is actually displayed here, which allows the biospecimens to be linked to electronic health information, and then you can also recontact the participants for future research, future surveys. Also allows for consent to connect to any external data sources through their social security number. So this is huge amount of data that you are asking participants for. And a prime example, a shining example of this worldwide is the UK Biobank, which has been game-changing for many of our research. But the patients, this is where I want to put some thought into it, the patients were recruited actually while they were waiting for surgery. So obviously, this is a convenient sample, perioperative sample. This is not representative of the population. What is the target population? Is it the people that we approach? Is it the people of Michigan medicine? Is it the people in the state of Michigan? Is it the people of the United States? So we have to define our target population of inference if you're trying to do any kind of inference. So electronic health record data has many, many parts. Primarily people use a lot of ICD codes or International Classification of Disease codes designed for billing purposes. But then there are lots of other components and other domains of data from which you glean information. So in order to define a disease phenotype, whether you have a disease or not, different structured and unstructured component of the electronic health records are used, including questionnaire data, treatments, clinical notes, and so on. And there's a huge team of medical informaticians working on defining these phenotypes, which often can be quite noisy. So I'm not going to give a talk on how to define phenotype, but some of the statistical challenges. So MGI, or Michigan Genomics Initiative, is obviously big data. And the core elements are medical phenotype, which are extracted from the content of the electronic health record, linked to biosamples, which is more than 20 million genetic variants after imputation. And as I said, as of June of 2022, it was 92,000. This year, we are at 100,000. But none of us probably believe that an individual's existence can be codified through electronic health record and genetics. So we have collected other data, questionnaire data on behavior and lifestyle factors, environmental factors, social factors, family history. On a subsample of people, we have wearable theta. COVID did not stop recruitment. It was an COVID stopped a lot of the surgery, so there are certainly challenges with respect to recruitment. But we started to launch surveys, and it turns out that during COVID, everybody was playing with their phone, and it was a very good time to do survey research, and there was a very good rate of response. We also started shipping spit kits and expanded our catchment area to the whole state of Michigan, and that was beyond our reach before COVID. So we innovated, taking the challenges of COVID into account. So at the end of the day, over 10 years, we had created a data system, and this is totally took 10 years. Each of these boxes are hundreds of people working on confidentially to preserving, privacy preserving, safe data connection, where we have the core elements, obviously, but then we link to, for example, I work a lot on cancer. We link to the University of Michigan Cancer Registry, the Tumor Biobank. Dental records are not part of the EHR or EPIC, so we link to that. We link to medical claims. We link to, from geocoded residential information, we coded into some of the neighborhood characteristics obtained from census data. And then we feed from additional data sources in terms of prescription claims and so on. So at the end of the day, we had a very integrated digital ecosystem. So when COVID came, this data set was linked to COVID vaccination outcome, long COVID, and also we are able to launch a survey quickly in order to take advantage of many of the confounders that are often missing in electronic health records. So why do I really like Michigan Genomics Initiative? There are many biobanks, but there is this opportunity to contribute to the patient population that you serve. And it is right there, sitting in terms of in the catchment area, but also the return of results and getting back to the community. And we have done many participant engagement studio, and I keep asking them, why did you give us this data? You see that there is 80% almost consenting rate in the recruitment procedure, and we hear a lot about people's protection of data, but why do you give the data? And the single most reason is that University of Michigan, in terms of healthcare or education, has a special meaning in their life because of personal experiences. That's why they want to give the data. So because we have this engaged participant community, in May and June of 2020, within 3 months of COVID, we are able to deploy a large questionnaire survey asking Michigan residents and our participants about their COVID exposure and experiences. So that's why I'm saying that when you start a process 10 years ago, you cannot envision the future. And so having this data infrastructure was really helpful for us. And then 2 years later, I went back and questioned myself. Did you really need that survey? This is a typical statistician that questions everything that you have done in the past. So could we glean all the information that we got from the electronic health records? What is the added value of the survey plus the electronic health records in terms of COVID testing and experiences? And it turned out that the survey was incredibly valuable. The EHR just is not enough. Based on all of these experiences of playing with data, gathering data, we actually collected data through an app called My Data Helps, where patients can actually consent to electronic health record at other hospitals and other healthcare systems through that app. That was game-changing because we don't have national health services, we don't have linked EHR data. Even in the state of Michigan, if you go to another provider, we don't have linked data, and this allowed us to get more complete view of a patient's encounter with the health system. So based on all of these, last year we got funded to actually start a population-based study. So this is 3 PIs from environmental health, epidemiology, and myself. This is a green cohort, and we plan to recruit 100,000 people from 6 environmental injustice hotspots in the state of Michigan. It's a $13 million study where we are truly trying to do a population-based 2-phase sampling. So I'm very excited that we are going to collect omics data and environmental biomarkers prospectively on a true disease-free prospective cohort who are aged 25 to 44 and monitor them over time. And this was sort of my dream study in multi-omics study. As you know, that temporality in terms of disease outcome is a huge cause of concern. And if you actually start prospectively and collect omics data, you can probably pick up changes in terms of biomarkers and intermediate processes much earlier. And again, by the time I retire, this study will not have enough cancer cases touched, but it will be a legacy, again, building up on the experience that I had as a statistician and an opportunity as a statistician to collect data. And I think this is incredibly important to think about electronic health records and biobanking and how to analyze those data meaningfully. Last year, this global biobank meta-analysis initiative was rolled out, and you can see that biobanks from all over the world are contributing with an incredible number of more than 2.2 million genotype samples. And I just have a joke that all my genetics friends are excited that an odds ratio of 1.01 is going to turn out significant. But I just want to show you that these biobanks actually really highlight what is going on, that these different biobanks are recruited from different mechanisms. Michigan Genomics Initiative, for example, here is a hospital-based biobank. UK Biobank is a population-based biobank. And then you have NIH All of Us, which is targeting underrepresented groups in science. So I just think that we need to think how to meaningfully harmonize and analyze these data sets recruited from different mechanisms. So, as a summary of Act 1, the data quilt that we created over the last 10 years, what is our vision is that we want a rich data set with large N and large P, which we can explore in. It's nobody's proprietary data. Somebody in social sciences can use it, somebody in pharmacy can use it, somebody in cancer can use it, somebody in diabetes can use it. And we can contribute to international biobank data analysis, as we saw that because we started in 2012, we are on that map. Many places are just getting started and they're not on that map. And it's a shared resource for the institution, pivot to address emerging challenges. And so my mantra to statisticians is going to be, create your own studies, own your data. With that is the first interlude. You need to cleanse your palates as we move to the second act. The second act is the main act where all the statistical characters try to come in. I gave this talk in India, nobody knew what this music was. Alright, so now that I have set up Michigan Genomics Initiative as a very good study, I'm going to be like the second reviewer in Royal Statistical Society. The first reviewer gives you a lot of compliment and the second reviewer tears you up. So now I'm going to tell you for all kinds of reasons why this is not a great study and you need to be careful. So all of us know that electronic health records are attractive because we built this very large cohort. Patients are coming to encounter and interact with the health system. It has a lot of variables. It has longitudinal data. The average follow-up time of participants in our study is about 7 years. It will cost you a lot more to do a prospective cohort study, as we are realizing with our true population-based cohort. The challenges are incredible. But what excites you is also this callback potential of giving results back, return of results, but also return of research back to the community. Many of the community partners actually come to our annual symposium and give us ideas for what we should focus on. In fact, this study, the MindCare study that you saw, the participants said you were doing lots and lots of work on genetics. What about the environment? Michigan is where the Flint-led crisis happened. You're not doing anything on the environment. Why this fancy genetics study? That led us to the population-based study, thinking about the environment more. So I think that these are enormously, incredibly rich data sets, but there is absolutely no experimental design. If we ask you what is the probability of recruitment, there is no probabilistic sampling scheme. There's all kinds of ascertainment bias, selection bias. You have to go back to your basic epidemiology and study design course in order to make sense of this data. So those are the cons. And EHR were not designed for population-based research. It was primarily designed for billing, and hospital administrators love it. All my clinician friends do not like it. They think that as they are looking at the patient, they have to enter this data. This is just too much. And then one thing I recently found out that electronic health records are really loved by medical malpractice lawyers. They just look at the EHR and say that, well, the temperature was this and so, you should have done that. So, but as data scientist, I quite like it because it gives me a lot of problems to work on, and we can only do some magic, not completely transform the data. So if you talk to people who are working on electronic health records, some of the main issues that they will probably all agree on is missing data because you do not have a complete snapshot. And why you see an observation is very informative because you have some kind of underlying health condition for which a test is ordered or you're seeing a physician. So by no means it is a missing net structure which is non-informative. And then you are also looking at confounding. You have looking at data harmonization and done it very differently across hospitals. Heterogeneity, true heterogeneity, biological heterogeneity in the study population, how to account for that. And then what is time zero? There is a lot of confidentiality in disclosing the time component of electronic health record. How do you define time and register time? And the 2 points I'm going to talk about today is imperfect phenotyping what do you miss, and selection bias, because those are two main issues in the Michigan Genomics Initiative. And in general, you might think that any EHR study has this confluence of catastrophes and all of these issues above. So it is very important for investigators to recognize which one are the issues that are most biasing their results or affecting their inference. So what are some of the bias reduction strategies in electronic health records? And some of these are coming from gathering new data, that you cannot do everything from nothing, so you need to get data on a subsample of people where you can go more in depth in terms of chart review, double sampling, multi-wave sampling. This literature is really flourishing in the last couple of years. You have lots of data, so you can use statistical design and use negative controls in a meaningful way. And then the third thing which I'm going to talk about is actually to understand the sources of bias and analyze them. You can posit statistical models for the data contamination process. How is the selection bias coming in? How is the misclassification coming in? So we need to, for big data, the main point I think I'm trying to convey is that you need to update your statistical thinking, focus on bias, not efficiency. In our, in our course when I did my PhD in 2001, we are focused on efficiency and power a lot, right? But not so much on bias, and that training seems antediluvian as we are dealing with this big non-probabilistic sample. And this is beautifully explained in this paper by Zhao Meng on big data paradox, that what is the curse of large N? And whenever I give this talk, my clinician friends absolutely dislike this. They say like, Bhramar, what kind of cynical people are you statisticians? Forever you complained about small sample size, you told us go get data, and now you're giving lectures on how small is your big data. And so it's like pathologically unhappy people that are trying to explain to you what is the curse of large N. So we have this big non-probabilistic sample where maybe I don't have huge bias, I have modest bias. Maybe my bias is of the order of like 0.01, 0.02, it's not that much. But now, my variance, because I have such a large sample, has gone insanely small, of the order of like 0.00001. So what is happening is that if T is the true parameter, almost surely you are going to miss it, not because your bias was large, the bias was okay, but it is not going away with sample size because it's selection and information bias. Sample size is not reducing the bias, but the variance is becoming insanely small and your confidence interval or credible interval is missing the true parameter. So as a result, you are being wrong with greater precision. If you be precisely wrong is your goal, that's okay. But we really need to understand the importance of bias in these large N studies, that sample size is somehow hurting me because if it was a modest study, I would have an opportunity to cover up this bias in my confidence interval. But now my confidence interval is perversely narrow. So there's something to be said about what is the true effective sample size that your data contain, and this paper is a beautiful exposition of that. So before you start analyzing any real-world healthcare data or big data, I think I want every investigator to confront these inside questions, that who is in my study and what is my target population of inference, if you are doing inference. I do think that there has been I love data science. All the tools that data science has given us in terms of machine learning and large language models are brilliant, but we have to really blend that with good statistics and good inference. So I do feel that we are really enriching our curriculum in terms of lots of computational courses, algorithmic courses, machine learning courses. If my colleagues in the computer science department is going to show a minimal gesture and introduce one credit course in sampling and study design, I do feel the world will be a better place. And I do think that it's the fundamental ignorance of study design and sampling that goes on to really take many mistakes downstream. So even if you have the best algorithms, I don't think it can rescue you from bad and biased data. And I do think this is very important because you are training the algorithms when you're building these exclusionary cohorts and training these algorithms, even the best possible algorithms. These are going to lead to incorrect policy decisions and further enhance inequity because it's going to reinforce itself and it's going to learn and reinforce itself. And there is this whole topic that we are not going to talk about, but how many algorithms, how many prediction models do we subject to fairness and equity considerations? How many data sets? The world's number of genomes that are collected, 86% of them come from people of European ancestry. So I do think that there is work to be done in terms of how data are being collected. So coming back to Michigan Genomics Initiative, when I took on my role as the Cancer Control and Population Sciences at the Cancer Center, this was a great database to look at because this database had about 50% people with cancer. And so certainly this is not representative of the population. In the population, 50% people do not have cancer, and obviously we did not recruit from the cancer center. So what is happening is that because you are recruiting from surgery, and cancer patients undergo surgery more frequently, and they tend to come to the comprehensive cancer center for their surgeries, there is an enrichment. And so there are different kinds of this enrichment in these biobanks. MGI is one particular example. So if you compare the disease prevalences in Michigan Genomics Initiative, so these are different disease blocks, as you can see here. These are not like genome, like chromosome blocks. These are disease blocks. And I've compared Michigan Genomics Initiative with the UK Biobank, which is a population-based study, and you have more cases or more prevalent diseases. So estimating disease prevalence is absolutely a no-no using a bias selection mechanism. But can we learn anything from this data? So in the beginning, because this is primarily a genetic study, we got very carried away, and we did lots and lots of research, particularly in terms of creating genetic risk scores, with a lot of work with many people, including Ingma, who is joining the Biostatistics department here next fall. We created this archive and repository of polygenic risk scores for cancer. It was an extremely successful project. But inside me, there was this something saying that how can this be right? This is not population-based data. We are just taking and pretending there is nothing wrong. This is almost like a statistical sin. So what was really, I was really challenging Gonzalo Adegasis, who launched this study, that this is going to be garbage in, garbage out, because we are not going to get any information, any meaningful information. But what really shocked me and stunned me is this plot, where genetics is an incredible field, where you actually have very large studies from which you have sort of a sense of what is the gold standard or what is the truth. So what I have plotted is for squamous cell carcinoma. This is just a random cancer I picked, but there are many other cancers, where on the x-axis I have plotted this population-based odds ratio, which is obtained from multiple studies, meta-analysis from the GWAS consortium. In the y-axis, I've plotted our poor bias study, Michigan Genomics Initiative, and the concordance coefficient is 0.9. And so where is the selection bias disappearing, and why is it disappearing? I need to know. Just its working is not enough for someone who used to be a person doing mathematics. So I wanted to really understand this, and so the two questions after this paper that I wanted to look at with my team is that why is it okay, and is it always going to be okay? And the other problem is that different people have there's a length bias sampling in electronic health record. If you have spent more time in EHR, we are more likely to catch your disease phenotype, and the same goes the other way. So how can we model these two things together in a statistical formulation? That's what the whole, in the last 5-6 years, we have worked on, that what is happening when you are not seeing a patient, that when you have less than perfect capture or observation window bias, and also when the patients are not coming from a random sample or even a probabilistic sample from the population. So for that, I think you really have to establish and think carefully about your sampling frame. That what do you have? This is the Michigan Genomics Initiative. 80% people consented. who did you approach? Are you trying to generalize to Michigan medicine or Michigan or US population? And what kind of data do you have on this external population? Do you have individual level data? Do you have summary level data? Because your statistical method is going to depend whether you have patient level data or summary level data on your external population. So I need to think about both of the issues in a mathematical model, and I do think that these two biases together matter. I just want to show you one example. This is a very well-established odds ratio of biological sex and cancer. Women are at lower risk of getting cancer, lifetime risk, and so it should be like this here. But when you actually include misclassification and selection bias together, which depends on selection depending on biological sex and so on, then you can end up here where you are going to get a completely different inference. So typically people say if you have measurement error, this is our typical sort of standard thing, that the odds ratios get attenuated towards the null, you have no problem. But you do have a problem when selection and misclassification are together at play. You can get quite opposite conclusion. It's not just attenuation towards the null. So what we did, and I'm not going to really bore you with a lot of equations, after all, this is supposed to be for the broader audience, but I just want to tease the people who think in terms of equations and models that we have three different processes here. In that sense, statistics is very similar in its epistemic knowledge in terms of philosophy trying to model natural phenomena. And so what we are going to do is actually create nomenclatures and models for things that we are observing and the things that we are not observing. So D star is going to be what we see, which is electronic health record derived disease status, but there is an underlying true variable D that we don't get to see. And similarly, S is the selection indicator that we only see people that you select. So S equal to 1 is the group that you see. You have no information on the group S equal to 0. And then there are different covariates which are informing, say, the selection mechanism or the observation mechanism, and we are going to posit models. So the goal is that you are interested in this disease model, in a model language. You say, I want to stay parametric here just to convey the intuition that you are after this true disease model, D and Z, but you don't get to see it. And you have posited some models for the selection mechanism, which are informed by covariates W. You have also posited some models for the misclassification mechanism on the selected sample relating D star to D with the covariates X and Y. Okay? So there are different covariates which are influencing different parts of the model, and you can be parametric, you can be assumption lean, but these are the different components of the contamination process that I'm trying to model. And what happens is that at the end of the day, this is the analysis that I was running for my GWAS and the initial work. I forget about D and D star, think D star is the true phenotype, and run it as if we did not have any selection, get these parameter estimates, and pretend they are the true parameter estimates. That's what we are doing. But obviously, we need to understand when that cannot work. So you can see that in the example I showed you, that it seems like theta and theta tilde were very close. You can ignore some of the misclassification and selection, but that's not always going to be true. So you need to establish a relationship between theta tilde and theta. And so we went on this whole journey to establish a relationship with lots of maths between, if you run the vanilla model, what is the relationship of the estimates of the vanilla model with what you are after. And what, at the end of the day, this is the beauty why I think mathematics is at the heart of everything that we do with big data, is that we relate and we establish a relationship of the model that we are fitting with the true model through certain quantities which sort of fell into places. These were the perturbations due to misclassification that folds into a logistic model. And this is the perturbation with respect to selection, which sort of appears as an offset term. But the problem is that they are all non-parametric functions of something which makes the model still quite challenging, the problem still quite challenging. But you can see things start to make sense, that how is your ordinary logistic model going to get perturbed by different factors which are influencing your selection and your misclassification. So at the end of the day, this was a transformed logistic model with an offset term, but all of these are very difficult to estimate. But still, this formula is insightful, so which gave us sort of to think about that how do we estimate C, how do we estimate B, and how do we actually relate the two models. We came up with lots and lots of algorithms using this transform logit framework, and how do we actually debias my previous cancer gender estimate to get something which is more sensible. Finally, for the selection piece, I have not still talked about the selection piece. How do you get estimates of that R? We basically went to, Michigan has a great survey research center, and people have done lots and lots of research on how do you use a population-based probabilistic sample to correct a non-probability sample. And there we did inverse probability weighting if you have individual level data available on the external population. But we did, if you only have summary statistics or marginals, then you can do rating and post stratification. At the end of the day, our methods sort of are summarized by saying that instead of fitting a logistic model, we were fitting a transformed logistic model. I'm still doing a lot of hand waving about those parameters, plus some form of weighting. And we showed that both of them are quite important in trying to reduce bias. Just handling one is not enough. Misclassification and selection together have to be handled together. And then, is it like always, are all GWASs okay? I was dying to prove my geneticist friends wrong by saying there will be one example where the population-based odds ratios, log odds ratios, and the Michigan Genomics Initiative log odds ratios are not going to be in sync. There has to be an example, and this is an example for age-related macular degeneration where we saw that the concordance coefficient is not 0.9, it's 0.55. So, but in a given data set, I do not know why is it off. As you can probably see that these log odds ratios are quite large. And AMD is an example where the effect sizes are quite large. Probably that's why you can see bias, but why are they not in sync? And if you throw my methods or our methods into this MDI estimates, do they get any closer? Can they get to 0.9? The answer is no, they cannot get to 0.9. Even after all of these methods that we have applied, you do not have complete information on the selection mechanism or the misclassification mechanism. The concordance and the accuracy improves with gold standard methods. It goes to 0.7, not 0.9. Because if we say that we can absolutely correct for the selection bias, that would be really wrong and false claim, because we can only reduce selection bias, and this type of bias will never have complete information why a non-probabilistic sample and individual data point is there. So in Act 2, I want to say that there's a lot of thinking from a classical statistical point of view, which gave us the architecture of this Act. And I'd like to say that we have proposed several strategies, which is more than 2 plus 2, but it finally gave me the answer. For me, I just wrote these papers to understand why those log odds ratios are tight and when they are going to fall apart, and can we assume that? And the answer for most GWASs, they are okay, is very simple. Because most of the time, selection or participation in a study does not depend on the value of a single nucleotide polymorphism, and nobody selects or consents to a study based on that, so that association is quite weak. But you needed to do the math to understand that when can you recover these estimates and when the situation is really complicated. So there is lots of papers coming out on this issue because UK Biobank has a very healthy control bias, and we recently wrote a paper deriving weights for major biobanks in the world. So even if you do not use these methods, I think you should be honest. if you're doing a study with electronic health record data, you should do a sensitivity analysis, taking your naive analysis, and say that if I change the contamination factors, what is my bias? I should be clear. And so we're trying to provide tools so people, at least, even if they don't do the whole modeling, can present some sensitivity analysis of the form like this, that if I upload my confidence interval by the naive method, is it going to go away with little perturbation, or is it robust to a lot of contamination? So we're trying to promote a culture of more transparency in real-world healthcare data. And we also created this package called Samba. I named the package. Selection and misclassification bias adjustment in R. Please, would love to have your feedback on this. And with that, I think we come to the end of Act 2, which was, as I said, the central act in terms of statistical ideas. So this is Samba. I gave this talk, and somebody said, I had another music, and somebody said, you just end the slide with Samba, you should have a Latino music. And so this is where it is. These are some of the references. I really like this one, where we take 3 case studies and show what kind of external data to use and how to fix some of the sampling biases. Alright, so the last topic act. So I've talked about data, building the data set. I have talked about creating all the methodologies to at least get at a disease phenotype and risk factor association in a less biased way. I'm not going to say an unbiased way, that would be a crime, but less biased way. Then when COVID came, because we had all the data and the methods ready, we could actually do a lot of rapid research in a nimble manner. So the US, as I said, that US EHR health data system is not admirable. There have been so many impactful papers in vaccine effectiveness, in terms of drug effectiveness from studies in UK with the National Health Services, Israel with the Collegiate health system, Denmark population-based registry. We realize that we have lots of good models, but we need good data. We need better data, and we have also appealed to our classical principles of matching, confounding, selection bias, meta inference, all of these issues in a very foundational way. I said during COVID is a time where we saw statisticians and epidemiologists making very foundational contributions, and the machine learners probably took a back seat. Those are the same compartmental models, understanding disease, understanding etiology, understanding study design was very important. So when COVID happened, because we had all of these, I'm going to draw a parallel to the problem that I just spoke about. Many of us took COVID-specific outcomes as my disease, and Z were many different risk factors. It kept changing. It was not always genetics. It was race. It was socioeconomic status. It was what happened to you before COVID, vaccine status, and so on. And the COVID outcomes, sometimes in the beginning, we were doing infection and then hospitalization, severity, death, and so on. Because we had this model, in the first part of COVID, testing data was extremely biased. This was a prime example of selection bias, and we needed to build models of who is getting tested, whose data are we seeing. And so we did a lot of work on building that selection model, or probability S equal to 1, or test equal to 1. And then we also compared different kinds of subgroup level comparison, one particularly in terms of the color of COVID. Even in an academic healthcare system like Michigan, the inequities are very present, and we kept monitoring these inequities over time when people have even stopped talking about COVID. I just wanted to show you this figure from our original paper in 2020, where we saw that the rate of hospitalization, severity, mortality were much higher in Black communities. And then 1 year later, we saw every severe event have gone down, but not in equal rate in the two communities. So I think it's important to have a good analysis which is closer to adjusted for various different factors which can create differences between the two subgroups. but have meaningful analysis and monitor it over time, this database actually helped us to use the same set of variables and examine the same question. We have done a lot of large phenome-wide association. When we first started this journey, the practitioners in the frontline health workers were asking us that who is at high risk of COVID-related hospitalization, because we did not have data. And that also re-emphasized for me that when you don't have time to do a population-based study for an emerging disease, electronic health records are incredibly important. So we did do phenome-wide association study. We were able to do vaccine and booster effectiveness study. This one is my very favorite because people were using long COVID, how to estimate long COVID and what are the post-COVID diagnoses that are happening. This study uses a design borrowed from air pollution literature, case crossover design, and compares what happens before and after COVID with what happens before and after flu or pneumonia or any other respiratory disease to tease apart what is specific as an after effect of COVID. So I think that the opportunities for EHR research has been wonderful. And I just want to say that sometimes people cannot foresee why am I doing Act 1 or Act 2, because you cannot anticipate Act 3, right? Because if you did not have the data, if you did not have the methods, you could not jump into, none of us could foresee COVID. So working with electronic health records has been both frustrating and fascinating, but I'm happy that I'm part of the team and not being just skeptical without coming up with solutions. So I just signed a book contract on really focusing on what is the data quality pyramid. If there is a checklist of sources of bias like we do in meta-analysis for EHR, what should I have to check off before going to New England Journal of Medicine with my finding? And so I think that I am a data dreamer. It's very obvious, 32 years of statistics major, what kind of a person is that? But I'm not the only one. And there are many, many people. I run a summer program in big data. The students are here on Michigan campus. I see the world changing one algorithm at a time. So with that, I just want to thank all of you for spending your Monday afternoon listening to a statistician. I want to thank every participant of all of these global biobank studies. This incredible research would not have been possible without your generosity. And then I want to thank Joe for his incredible, immaculate hospitality and a long-time friendship. Thank you very much.
So Bhramar, that was a fabulous tour of statistics. It's sort of even, not surprisingly, reoriented some of my own thinking as you were talking through this whole process of how should we be teaching statistics. Yeah. You know, instead of starting with linear regression, thinking of like, what is the estimate, what are the data, can the data inform us about this process we want to learn about? I really think that has a lot to, that's going to have a lot of influence over how we think about statistics and teaching it. Probably not just here, but in a lot of other places. So thanks for that insight, and also the contributions you made during COVID. I mean, not just EHR, but I think Ashish may not have given full justice to like all the contributions you made, not just in India, but here in the U.S. In Michigan, helping us learn about the impact of COVID. This paper that you just mentioned about long COVID is something that I think we're all going to be checking out because there's several of us around here. So not only did you sort of respond in the acute phase, and I think it's fair to say we were all watching from afar just the huge amount of work that went into putting together models of the epidemic itself, but now also gaining insights even 3 years after the acute phase is really remarkable. So thanks for sharing all of that with us. So I think I'll stop and see if there are questions for Bhramar. There's a lot here to consider and think about. So I'll stop my sort of piling on of accolades and appreciation and turn over to the audience to see if there's some follow-up questions for Bhramar. Yeah, Ron.
So, first of all, that was a masterful talk. Thank you so much. Very early on in your talk, during Act 1, when you started explaining how all these different data assets were brought together. So the naive thinker like myself would say, wow, how does the social security number sort of interact with these places, all these other assets that are not necessarily, are they all under the umbrella of the consent, or is there some sort of anonymization at some point that just maintains uniqueness of the link?
Yeah, that's a great question. So, as I mentioned, that this was a lot of work over 10 years, and each box took lots and lots of paperwork and IRB clearance and also privacy and confidentiality preserving tools. So, the fact that we could link by social security number was a part of the consent. And the fact that we could call back potential was a part of the consent. But then how do we de-identify and encrypt the data so that everybody who is a user gets a random encryption ID so that we could not even merge or de-identify people? A lot of medical informaticians and computer scientists work on that encryption factor. And till this date, only very few people can link all the components of the data. Other people with lower level of privilege can only link 2 components, which is not enough. And also there's a lot of pseudo data creation where we add noise to some of the geocoded information, for example, the census level variable. So there is a lot of thinking at a granular level, which you not even appreciate as a statistician whether you're just looking at the spreadsheets. But they come in for each of those little boxes. Yes. It's just like a massive enterprise.
Yeah. Thank you.
So I think you had a question?
Yeah, it was back to when you were looking at the factors of people who consent. And I wondered if you looked at the probability of consent for various populations.
Yes, we actually did. And that is one advantage that I want to point out, that if you are recruiting using EHR data, usually you can glean a lot of information on the people who are not consenting. Because you have a general permission to look at the medical EHR when you seek treatment. So from that, we could actually get so it's very interesting that initially there was less participation from historically marginalized groups. But then we started a particular branch of precision health only targeting and promoting and building community partners in particularly 2 communities. The Black community in Flint and Detroit, as well as the MENA population in Dearborn. We have Michigan has one of the largest Middle Eastern and North African population in Dearborn. And we really established strong partnership. And I think now it looks much, much better. And so I just give you some numbers. Michigan University, the whole state of Michigan has about 14% Black. Michigan medicine has about 9%. We used to be about 4%, 5% in our biobank. Now we are at 8%. So I think that it's little, but you have to really target that in order to ensure it's representative. Or it should be more, but you have to do it. The cost of recruitment is much higher in those communities, but we have to go there. And that has been our focus, that do we want the sample size of 10,000 European ancestry genome coming our way every day, or with the same budget we are happy with 2,000 diverse genomes, and we have assented that we want 2,000 diverse genomes.
A question for Bhramar.
So I want to, nobody else wants to.
Go ahead, Ron.
Let's go back to the teaching question that sort of Joe framed right from the beginning, because I was in the industry for a long time, and then there was this shift towards everybody's looking for a Bayesian statistician all of a sudden from a frequentist, and so I love the idea of having people trained in multiple disciplines. How do you sort of actually think about that in an operational way?
Yeah, so that's a great question. So, I cannot change the Michigan curriculum overnight, but I run this 6-week summer program where I have this omnipotent stature as center director to do whatever we want in terms of shuffling and permuting the lectures. what we have done is really go back that, throw them into data, think about problem, like what are you trying to get at? Because many times they think that a statistics course is expectation y equal to x beta or some function or something, it's going to start like that. But it does not really have to start like that. It can start with the problem. And math undergraduates actually really like the logic of potential outcome. That they like this 0, 0, 1, 0, which is sort of like for us to get used to the causal inference potential outcome notation takes a while. But for them, that comes quite naturally that you're manipulating things and these are different combinations that could happen. You don't have data on all possible combinations. Let us see what assumptions you need in order to identify that. That comes logically. It's almost like if I did not know any other language, whichever language you teach me, I'll learn. And so it's a clean slate. They don't come with a lot of stat and math courses if it makes sense to them. And then for their projects, when they go down that their research project, some people really get fired up about, I saw this package in Bayesian, I'm going to try that. And then they go deeper into that. And so I feel that if you give them option instead of prescriptive statistics, I think that people are going to learn. And with a lot of tools being available, learning the software and the tools was a big learning curve, steep learning curve for someone who got a degree in 2001. But not true for someone who got a degree in 2021. These people were playing with their iPads, their parents did not talk to them. So I think that, like me. So I think that they're fearless. They try everything and they figure things out. So I think that to expose them to different schools of thinking and giving them a choice that you can deep dive into a particular thing. So it's sort of a T framework of learning. That you learn a lot of things, but in order to solve a problem, you have to go deeper. And many times you don't have to work alone. You can work on a team where there is a Bayesian person and then you are a causal inference person and there is a machine learner all coming together. You don't have to just create for individual credence and glory.
I can relate that on some level. I was helping teach the intro course this past year, and I opened up a standard intro statistics book in the year 2023, and it's dreadful. I mean, so it's like, okay, I wish I could take out 2/3 of the pages. The business of starting with an interesting problem and then building the tools around it and then building the formulas. I think it makes a lot of sense. It's more interesting, as you say, to audience of young students today. So.
And people coming from math, directly from math, when they have not been indoctrinated with our modeling, generalized linear model and linear model courses, potential outcomes make more sense to them than linear algebra. I have to tell you, this just makes combinatorial sense to them.
Mm-hmm.
But we have to sort of justify our identities in the era of large language models and ChatGPT.
Yeah.
So every class I go to, I have to defend myself. Well, about this topic, this is what GPT-4 is saying. Let me think that what can I tell you? And for that, I think I have to come up with a lot of the innovative things and rudimentary things as I learned that I, as a human, can defeat a chatbot. So, I don't want to get started on that, but I start all my lectures saying that, well, I know that you're going to do this, so let me just tell you what ChatGPT is going to tell you, and then let us look at that and what additional things can we glean in so that we can use the class time in meaningful dialogue.
Yeah. All right, maybe one more. I know we're over time.
Okay, the last candy bar. Whoever asked the question. Yes, please.
All right, so I've been wondering this since grad school. So, is there a SNP for loss to follow-up? And I'm partly serious because I know you can't do it at baseline for participation because you can't observe the non-participants, but you could observe it for people who are lost to follow-up. I mean, it could just be totally meaningless, but I mean, there's SNPs there's polygenic risk scores for educational attainment and all sorts of other nonsense now, and so, it's plausible.
So this is a very good idea, and I have not done this, but I think this is one thing we are doing, and this is sort of related to your idea that how do you use polygenic risk scores for addressing selection bias and missing data, the broader question. So what we have done
because electronic health record data, this is very problematic in terms of biomarker data, right? That I have lots of vitamin D levels in my EHR because I have vitamin D deficiency. And so that's why you are seeing frequent and somebody else may not have it. So if you actually, I don't have vitamin D data on everybody, but because I collected genetic data on everybody, I have the vitamin D polygenic risk score, which can tell me that if I have high polygenic risk score, I'm more likely to see an observation. So this idea of using polygenic risk score as a predictor of when you are supposed to see an observation for the observation process, the advantage is that polygenic risk score, you have a complete data on everybody and it's not changing over time. And if you think about that as a very weak instrumental variable of the whole missing matrix of biomarkers, it is actually quite useful in terms of imputation because it gets the correlation structure. So I think that there is tremendous merit in terms of thinking how genetics could influence and help build those selection models or misclassification models, and how can we use polygenic risk score as a surrogate for missing vitamin D or missing BMI. Not everything, but something.
All right, so I have a lot of questions for you about like how can you be a department chair, lead this department, and then also give a talk like this. And so this is going to be a secret I'm going to try and extract from you over dinner maybe. But it's really remarkable, Bhramar, and thanks for sharing the sweep of your work over the last few years. And it's a terrific lecture. And thanks everyone for coming.
Thank you.